Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. We're here at the HIMSS 2023 conference, and our guests are Paul Wilder, he's Executive Director of CommonWell Health Alliance, and Liz Buckle, Director of Product at CommonWell Health Alliance. Welcome, guys.
Great, thanks for having us.
Yeah, thanks. Happy to be
Great
here.
to be here.
Yeah, so excited to learn more about all the stuff you're doing. I mean, it seems everything's happening with interoperability right now, lots of exciting things. But Paul, how about you tell us a little bit about yourself and CommonWell?
Yeah, so CommonWell is a trade organization, trade alliance made up of mostly EHR vendors, other HIT vendors, all the common mission to solve interoperability problems, right? It's not really a problem as much anymore. We have a lot moving around. Today's problem is getting to TEFCA and getting the rest of the stuff connected and moving on to new use cases beyond provider and treatment. So we're here to proselytize, I guess, get people moving that haven't moved so far. But we're very proud of our success in the last 10 years. So,
yeah. I agree. Interoperability is not the problem. Adoption's the problem. That's where we're at now. Liz, how about yourself?
Yeah, absolutely. So I've been in this space for almost 10 years. Started out on the EHR side, actually implemented CommonWell services at that EHR vendor, and then joined this team. And like Paul, excited to be here and talk about where we are, where some challenges still remain, and what we plan to do about that.
Great. Well, Paul, you were on multiple panels here at HIMSS on TEFCA, Q&As. Everyone wants to know about that. What are you hearing that's new compared to last year, and maybe 1 to 2 takeaways from it?
It's interesting. It's kind of like old is new again. Everybody's very interested in interoperability. The weird thing is sometimes you get people coming, what do I do? Like, what's different and what's changed? And I was in a speech yesterday, or a panel yesterday, I said, just get connected already. Like, we already here, you don't have to wait for TEFCA to get connected.
Right.
Every Q&A that I know of so far can connect you now to a national framework and do national exchange.
Wow.
TEFCA, we're just hoping gets the rest of the 20% of the data we're missing to get coming and connected. So it's kind of the same message we had 10 years ago, but get off your butt and get moving.
That's really interesting, and you're right. Why are we waiting? We don't need that. We can start providing value even if it's not 100%. What a great message. Liz, as Director of Product for CommonWell, you've been in the Interop Showcase, which is a huge feature here at HIMSS. But tell us more about Teresa and why the services your members have been illustrating at the Interop Showcase are important to CommonWell now and also in the future.
Yeah, absolutely. So to Paul's point about getting connected now, we are demonstrating a lot of our core services right now. And it's cool because we're demonstrating them and we're connected with our members. But this is real. This is real exchange that happens at scale today within this national network. So Teresa is a working mom. She lives in Hoboken. She's actually a hodgepodge storyline between experiences that both Paul and I have had.
Oh, interesting.
And so we highlight our core services. We talk about the Master Patient Index, why that is so important from a patient matching perspective. We talk about the Record Locator Service, or RLS, and why we feel that the RLS is really critical, almost vital, right, to the success of national exchange, the ability to figure out where the patient is quickly and efficiently without having to ping everybody in the universe to figure it out. We talk about our data broker, and we're starting to talk more and more about FHIR, and not just FHIR APIs, because FHIR APIs are around. They're everywhere, but how do you do that in a scalable way that's secure, that makes sense? So those are some of the things that we're talking about with Teresa today and through tomorrow.
Interesting. Well, I love that you put a persona to it. That really matters.
Yeah, it's pretty close to an accurate real story.
It is.
We took some pieces out because it got more complicated. I say you asked the question before, like what's new? What's interesting is more people are bringing stories about their own interoperability observations, which is a little different. Like you think about, like I had a family member who had cancer, and they talk about trying to find all the records, so they're their own record locator, which is bad. You should already, if the system knows where they are, just go get it.
Sure.
And you still had to print, and this is only about 4 years ago, you still had to go collect and print out a lot of data. Yeah. And now I'm getting more and more people coming up and saying, it's starting to work. There's still a couple of gaps, and I still had to do some manual work. We got to finish the job. Right. So it's interesting. People are bringing their own stories in. They're observing kind of the former issue that's becoming more of a current solution.
I'd never thought about it, but I think you're right. Everyone that talks about the problems in healthcare almost always points to lack of interoperability when they're telling me the stories. Yeah. That's so true. Well, and you mentioned FHIR, which everyone I think is like, what's happening with FHIR? You know, you did a CommonWell FHIR Connectathon with a bunch of members, I think 11 members, you know, if my notes are right, but tell us more about that and how CommonWell is approaching FHIR.
Yeah, absolutely. So as I had mentioned, FHIR is sort of everywhere. You see it all around the HIMSS floor. Everyone's talking about it. It's definitely in the Interoperability Showcase. What CommonWell is doing right now, and we did have a Connectathon last year. We continue to test with our members. We're demonstrating it again this year on the showcase floor. But really the critical component that we feel is missing, that we want to bring to the forefront and shed some light on, is around the security portion. So without going super technical, there's a security implementation guide that is now a balloted HL7 for trial use, standard for trial use. It has a very long name, but we call it the UDAP Security Implementation Guide. And so we're really pushing for a dynamic versus manual way to securely register and gain authorization to query for FHIR data, because it's still very point to point today. It's still very handshake, I need to know you, you need to know me in order to make this work. And that's not how CommonWell works at scale, right? We have over 34,000 provider organizations connected. We can't go knock on everybody's door and say, hi, do you trust me? That's not how a trust network works. So we're trying to bring this UDAP security implementation guide to the forefront so we can scale trust in a way that we've done already with the document exchange.
Yeah, it's almost like, imagine if every time you tried to buy something with your Visa card, they had to call your bank to say you
exactly
and check your account. It doesn't work. You need to
work.
do things at scale. The computer needs to respond now based upon some trust framework that allows it to work.
Yeah, that's a good way to look at it. Now, Paul, you know, as I was getting ready for this interview, I saw something you said. I'd love to hear some thoughts on it, but you said interoperability is a bit of a slog, and you have to be part of the willing to make it work, which I thought was so fascinating. So, you know, could you speculate on what might help it feel a little more seamless? Is FHIR the answer? You know, is it TEFCA? I'd love to hear your thoughts.
Well, first of all, I'd like to think that CommonWell is part of that solution, right? So we have a community of members that every day are making it easier for themselves, and the first movers pave the way for a spec that just works, right? And I think, quite frankly, I don't think that's unique amongst the QMINs that are out there in TEFCA. Everybody has a way of connecting inside versus outside. And quite frankly, I think we compete on the simplicity of the inside stuff with making the outside connectivity be just simple, right? They don't have to know what that is. I don't have to know how my iPhone or Android device works. It connects to AT&T and I can make a call to anybody. It just needs to work. So the slog part is that we're trying to make it simple for providers and the users of this technology. But if you're a developer of the technology, the slog part is it's not a magic bullet just to connect to CommonWell. You do have to build workflows and think about how are my users going to use this data?
Right.
Because the stuff that's coming out of CommonWell or Care Quality and TEFCA in the future, it's a lot of data. And some of it's structured, some of it's not. What does your provider, what does your user want to do with this data? And you have to build that. So you call me up and say, great, I just need interoperability, I just need that service. We have a conversation of what's your roadmap? What are you developing in interoperability? Where are you on this journey? And when they say we don't know yet, we go, I'm not saying don't sign up because we'll help you figure it out, but we need to get you a little further along for you to get true benefit of the bargain here.
Yeah, that makes sense. And I think it's also interesting, you worked 10 years at NICE, right? The New York eHealth Collaborative, which I've gotten to know well over the years, but let's talk about the HIEs as well, right?
Yeah.
And their involvement with it. You know, there was a report that said that 56% of HIEs are going to participate in TEFCA, which I think is low. I think it's going to be much higher personally, but there's my own take. But you know, what does that mean to really that connectivity between public health and providers, and is that a groundwork for the future as far as, you know, pandemics, and hopefully we, God forbid, we have more, but you know, probably will, or maybe even other public health requirements and emergencies? Yeah,
it's a great question. I mean, if you look at public health, I think, by the way, is the easiest use case that we're all happy to adopt as the next thing to add to all the frameworks.
Yes.
I tell people this, under Care Quality, I'm not sure if you know this, but under Care Quality, with CommonWell support and support of the implementers there, when COVID hit, we made a rule that any public health department that wants to join the framework can make a treatment-based request, even though they're a public health department, because we know that machinery works. Right, it's a standard hack thing. I know this works, I do it that way. They didn't take us up on it.
Really?
Right, we had one state. And so what you learn there is it's not always technology, there's policy involved too, right? They didn't know if they're allowed to, it's minimum necessary.
Gotcha.
A certain data, if I get this large document, 2,000 elements, but I wanted 11, have I done something wrong? So, you know, I think TEFCA is going to help us bring that conversation to the forefront. And I think the HIEs could play a very significant role. If you really look at the HIEs, they started out looking at CommonWell as competitive. And you can find like video from me from 2013 saying, I don't think so, I think it's very complementary.
Right.
And I think that's played out, right? The HIEs have become service providers to the public health department, to the Department of Health, to Medicaid and others to do local analytics and warehousing, all the things needed to figure out how to do healthcare in the state, not just provider exchange, because quite frankly, the national frameworks do that better. So I think they're going to play an important role in this next use case expansion, and then whatever else besides that we haven't even thought of yet.
Yeah. Well, it seems like many of them are trying to figure out, are they a utility? Are they, like it's to your initial point, like, okay, it's one thing to get access to the data, but how do we make it useful? I think some of the HIEs are figuring that out finally,
right.
And what is the business model that makes sense for them?
Exactly.
So, but Liz, I mean, he has an interesting background with HIEs. Yours is the other angle, as you kind of mentioned, that you were a founding member of CommonWell as part of Greenway. Interestingly enough, you're the first woman to be a full-time employee in your role at CommonWell. So is there an unexpected thing that stands out in your journey with CommonWell? And maybe talk to us about the importance of making sure women, there's a lot of women in health IT stuff here at HIMSS, which is great, and maybe other diverse voices as well, are heard when it comes to health IT and healthcare.
Yeah, so I'll break that up a little bit. So on the first side, I don't know that it's necessarily interesting or unique, but it's been nice to be able to take a step back and take a look at CommonWell day one and just trying to get adoption, just trying to make, is this thing going to even work? This was a brilliant idea, but there's a lot of brilliant ideas that don't turn out. Middle way through, okay, we're gaining adoption. We became a care quality implementer. We saw adoption on both sides really skyrocket, and that was amazing. To Paul's point today, there's a lot of exchange happening and there's a lot of data moving. What are we going to do with that data? So it's been really interesting to sometimes zoom back, take a step back, take a look at what's been going on, and what challenges remain for us to then zoom back in and start to tackle. We had some conversations yesterday about data quality and minimum necessary and how do we get these other use cases beyond public health? There's a lot of other use cases that we feel strongly about that haven't gained the adoption that we would like to see. And I think even before we get to that point, it's, first, how do we get these other folks connected? We're doing really well in the treatment space today. Now, CommonWell, looking forward to the future is, okay, what else can we do well? We have built this foundation. Now, where do we take that foundation to benefit more within the healthcare space? And then on the seeing more women in health IT, we're all consumers of healthcare, all of us. And, Paul and I have a lot of conversations about our own experiences within the healthcare ecosystem as patients, as consumers. I don't always think about how many people are in the room or who's at the table, because as Paul knows, I'm not usually hesitant to not speak my mind, regardless of male, female. But what was interesting is we were in a meeting yesterday. We were in a round table where we were able to offer our feedback as a candidate QHIN to some federal partners. And I actually took a look, and it was an even 50-50 split of who was at the table. And that was really encouraging to see. Again, not something that I'm always thinking about, but just here today, 2023, it was really nice to see a pure, even split, voices being heard from all different types of stakeholders. So that was great.
Yeah. And I think we've seen the results, right? When there's more diverse voices, it produces a better quality product and more people benefit in the way that they should. So.
Oh, absolutely. And also, she was the first female employee. It's only the third employee ever hired by CommonWell,
Sure,
actually. So
fair
it didn't take us too long to get there. And every full-time employee except for myself is actually female.
Right.
What's interesting, what I find is, and I don't want to mess up societal norms, things shift over time, but if you go back not too far in our distant past, the mother was probably more likely to be the one tracking the care of the children. That's a big part to look at, right? There's a lot of healthcare, and interoperability in particular, is about telling stories. And a lot of it's about observing the stories to be able to tell them. You can't just steal from other people. You got to make it personal. And it's very easy to make it personal if you just look. And a lot of mothers have a lot of stories, right? So it's actually a perfect place to be, because you get to take those stories and say, here's what's wrong. You may not have noticed, I did. and I want to fix it.
Absolutely.
It makes sense why you did Teresa, because the mothers are the caregivers often, so that makes a lot of sense. Well, Paul, to close us out, what are you most excited about over, say, the next 10 years for CommonWell, but also for the nation and interoperability and all of this exchange of data as a whole?
Well, this time it's actually a very easy answer. The next 10 years after that's going to be hard, right?
Oh, interesting.
What I'm expecting from here to the 20, so it's funny you mentioned day 0 or day 1. I was trying to calculate what day we're at now in CommonWell. I think it's somewhere around 3,700 day.
Wow.
And I think we're going to see that adoption finish, right? And add a couple use cases. In 10 years, it gets weird when you say, okay, everything's connected. Now what do you do, right?
Interesting.
Because we still have, I'm not sure if you've done the numbers. We talk about 80% of the data being available through CommonWell and our frameworks we connected like care quality. But that's actually about 20% of the sites, right? We talk about, we have 34,000 sites. Care quality mentions about 53,000. If you look up reports on how many ambulatory sites there are in the country, there's about 210,000. So the quick math says we're only about a quarter. And, you take the hospital aside. So there's I think it's a health equity thing, right? So the provider that's not connected in a rural whatever, it's on an EHR we've never heard of, is not intentionally doing a disservice to their patient population, but they kind of are when that person moves or gets connected or goes to a hospital. The data isn't available to flow. So I think the next years is finishing that job. It could take that long, right? This is the electrification project of putting all electricity across the country, or even you saw cable, right? Putting cable into disproportionate socioeconomic societies, going, we need to get you connected because you're gonna miss out on something.
Right.
So I think we do have areas and pockets that are missing out on something that we got to get connected. I think that's our 10-year goal. After that, I think it's a huge acceleration in use cases. Right? Healthcare takes a long time to move. I wouldn't expect this to happen overnight, but I'll say 5 years to finish to 95%. How about that? And the remaining 5%, we'll take that remaining 5 years while we add other use cases.
Well, it's a fascinating 80-20 rule, right? And I think it is a health equity issue. I think that's a great description of it, because that last mile is always the hardest. As you said, with telecom, we've seen that. With broadband, we've seen that. So many of those issues. So yeah, but it is exciting, right? 10 years from now, when all the data is available and you just have to, then it's like, well, what are we going to do with it? But I think we can start doing that today.
The other thing I would say is that's when innovation can really happen, because part of the problem of a partial record is you don't know if it's worth investing what to do with it, because it's kind of advisory data. Here's data I got. I still have to ask you the H&P. I still have to have the whole interview with you about your health history, because it might be missing in there. Once it's everything, you can rely on this as part of the clinical flow and say, I'm going to let the clinical decision support really run with this thing and rely less on the interview. And that interview, which takes 2 minutes or so out of a primary care visit that's 7 minutes, that's a significant portion of the thing. Now it could be verify, not interrogate. And that can change clinical workflows dramatically once we get there. Yeah,
great point. Well, Paul, Liz, I really appreciate you taking time to share these insights and perspectives, and appreciate all the work you do at CommonWell. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcast application. Thanks.
Thank you, John.
Thank you.